Good afternoon. I am Autumn Saxton Ross, the Program Director for Place-Based Initiatives here at the National Collaborative for Health Equity. I want to welcome and thank you for joining us for this month's webinar, From Policy to Practice, Building Health Equity in Boston, led by our Boston Place Matters team. Feel free, if you want to find out more information about Place Matters, our Boston Place Matters team, or the National Collaborative for Health Equity by going to www.nationalcollaborative.org. We also invite you to tweet us at NationalCo using the hashtag Health Equity in Boston. We also would like for you to ask your questions as they come in using the chat box to the left, and we will have time at the end of the presentation of the webinar to answer these questions. So you may ask, what is Place Matters? Place Matters is a national learning community made up of 19 multi-sector teams working in 27 jurisdictions. This initiative began in 2006 with a grant from the W.K. Kellogg Foundation. And what we do in
All
Place
attendees
Matters
are muted and may unmute themselves by pressing *6.
What we do in Place Matters is really use communities as both the identifiers of issues, but also have communities develop the solutions for the root causes of health and equity. We seek to focus attention on the root causes of health inequities and to improve neighborhood conditions for health by building multi-sector coalitions. We have teams that range from people in health departments, from faith-based organizations and nonprofits, city planners, naturalists, and the gambit. We believe that by raising public awareness of the inequitable distribution of health resources and risks across communities, that is key in starting to address these situations. And we seek to identify and build support for evidence-based policy solutions. Our mission is to build the capacity of leaders and communities to identify and address the social, economic, and environmental conditions that shape health and life opportunities. We believe that every community is socially and racially just, and there are equitable opportunities for all. And if you look at this picture, this is the lens with which all of our work comes from, is an equity lens. We believe that people should be given what they are needed to be successful. Right? Equity is a process, and we must have equity first to then start to achieve equality. So with that, I would like to hand over the mic to our wonderful Boston Place Matters team to discuss their work on building health equity in Boston.
Thank you so much, Autumn. I'm Vivian Morris here in Boston as the Boston Public Health Commission. We like to give very special thanks to the National Collaborative for Health Equity for being our supporter and ally for our work here in Boston over many years, and also for hosting this webinar. The work we'll describe would not have been possible without civic leadership here in Boston, and we want to thank our Mayor, Martin Walsh, for his support of our work at the Boston Public Health Commission, and also give special thanks to our interim executive director here at the Boston Public Health Commission, Dr. Wee Nguyen. I want to also introduce the rest of our presenters today. Michaela Manukian, who is the program coordinator in our Office of Racial Equity and Health Improvement. Brad Cohen, who is our director of the Consortium for Professional Development, and Michael Suhu, program manager also in the Office of Racial Equity and Health Improvement. We have a number of objectives today. First, we're going to introduce the Boston Public Health Commission's Racial Justice and Health Equity Initiative. Throughout the presentation, we'll be sharing how our work has progressed from policy initiatives to staff development, building our practice, evaluating our outcomes, and learning lessons to inform our next steps. Today, Michaela is going to describe our internal policy change efforts Then Brad will describe our staff development work. Michael will give a detailed example of some of our efforts to change our practice, and then I'll come back in and talk some about recent work that we've done where we have some preliminary outcome data, and then end with our lessons learned and time for discussion and questions at the end. And again, we want to remind and ask you to please submit your questions all along, and then we'll answer as many as possible at the end of the presentation. The mission of the Boston Public Health Commission is to protect, preserve, and promote the health and well-being of all Boston residents, particularly the most vulnerable. So just a little bit about our health department. We are the oldest health department in the nation, in the United States, having been established in 1799 with Paul Revere as the first president of Boston's Board of Health. But in alignment with our mission, we prioritize our most vulnerable populations and include among our many services homeless services, addictions prevention, treatment, and recovery services, emergency medical services, and many others. We have 1,100 people among our staff, and we're all driven by our mission, and that mission grounds us in racial justice and health equity. Here in Boston, Commission employees are also subject to a Boston residency requirement. And for us, that provides us with a workforce that not only has an added stake in improving our city's health, but also staff that bring to the job their intimate knowledge of living conditions in the city. So here's some little facts about Boston. We're a city of a little more than 500,000 people. It's 630,000 residents. And on any day, the number of people in Boston is up to as much as 1.2 million when you add in visitors, commuters, students, and others. We're also now a majority-minority city, with blacks, Latinos, and Asians combined making up 49% of the city's population, compared to whites who make up 47%. You'll see in the graph also that the cost of living in Boston is one of the highest in the country, and all can afford to live here. The median income for white families in Boston is double or more that of all the other groups. 23% of our residents live below the poverty line, and that burden disproportionately falls on non-whites. And for black males, unemployment in 2010 was 32%. And you can compare that with the city average the following year in 2011 of 6%. From this map of Boston, you can see that Boston shares with other major cities and towns an ongoing legacy of racial segregation, with people of color overwhelmingly residing in Boston's central corridor. And you can see that one zip code here, as we'll see later in our discussion, that one zip code generally reflects one's health. Again, looking at this map, you can see where the largest numbers of black, yellow, and green dots, which go, again, down the center of Boston. So here are a few examples of the connection between where one lives and one's health. You can see that for many health conditions, residents experience adverse health, and that the location of where those adverse health conditions exist, again, looks similar to those corridors down the center of Boston. These graphs of Boston that are color-coded show non-fatal gunshot stabbing, emergency department visits per 1,000 residents, the percentage of obese adult residents, chlamydia incidents per 100,000 residents, and low birth weight. And again, the darker coloration tends to go more down the center of the city of Boston. Our mission, as we've just described, is to protect the health of our residents. And the data we just shared and the similar data on many other health conditions pushed us as a health department to look more deeply at the underlying causes of health inequity. These social determinants of health provide us with a framework for looking further upstream at health impacts. Racism has an impact on each of these social determinants, and in addition, racism directly impacts direct individual experience through the physiological effects of stress. So we want to use education, one of these social determinants, as an example of this framework. In 1974, federal judge Arthur Garrity ruled that the Boston School Committee had for years, and quoting him, intentionally brought about and maintained racial segregation, end of quote, to keep black children away from the best schools in the city. He ordered black kids to be bused to what were then white schools and vice versa. Many of the participants in this webinar may have seen images from Boston during this time of the Boston busing crisis, where little black and brown children were targeted for racial hatred. We never measured the impact of stress on these children and their families, but today that impact still exists, with our schools being as segregated as ever, and we're still working to decrease the academic achievement gap. This is a definition for health equity that we develop and use here at the Commission. It was developed through an internal learning and sharing process. And it says the opportunity for everyone to attain his or her full health potential is, again, the goal of health equity, where no one is disadvantaged from achieving this potential because of his or her social position, for example, their class or socioeconomic status, or socially assigned circumstance, like race, gender, ethnicity, religion, sexual orientation, or geography. Now we'll talk about how we use this definition. What we see here is a pictorial representation of our Racial Justice and Health Equity Initiative. Since 2005, with the support of Boston's mayors, the leadership of our executive directors, our Board of Health, our staff, and with funding from key federal grants like REACH funding, we've been consciously working to reduce and eliminate racial and ethnic health inequities. Trainings were provided to our staff by groups like the People's Institute for Survival and Beyond, Visions, Inc., and the Interaction Institute for Social Change, and all of them have been very important in helping us grow. Over time, we've developed our internal capacity by forming structures and committees to support our work. We now describe those structures as our Racial Justice and Health Equity Initiative. This initiative aims to engage our entire commission in building a movement to fulfill our mission. I'm now going to turn over the discussion to Michaela Manoukian, who chairs our Anti-Racism Advisory Committee, to discuss how policy change towards racial justice and health equity happens here in our health department.
Thank you, Vivian. Hello again. My name is Michaela Manoukian, and I will specifically be talking about our Anti-Racism Advisory Committee at the Boston Public Health Commission. So we will be showing a 90-second video, so I want to remind folks and alert them to adjust your volume so you can hear. And this video was created by the Anti-Racism Advisory Committee with our communications office and others in order to share more broadly with staff specifically who we are, the work we do, and why we do it. So here we go.
ARAC is a group of commission employees that meets twice a month in order to fight health inequities that affect the health of Boston residents.
ARAC develops policy recommendations for senior leadership based on meetings and surveys of BPHC staff. ARAC recently completed the development of an organizational identity statement to keep all of BPHC's work in line with its mission and goals.
The Boston Public Health Commission
envisions a thriving Boston
where all residents live
Healthy, fulfilling lives
free of racism,
poverty, violence, and other systems of oppression.
All residents will have equitable opportunities and resources,
leading to optimal health
and well-being.
Join us. Help us make this vision a reality.
Hopefully that paints a clearer picture of who we are within the Anti-Racism Advisory Committee. And I want to walk through some of our goals. So the Anti-Racism Advisory Committee at the Commission works towards organizational change. It was founded in 2008 with the priority from our leadership and focuses internally on policy and workforce development. With the support from the People's Institute for Survival and Beyond, ARAC created its goals, which are specifically to align our internal policies and practices and structures in a way that organizationally we are aligned with promoting racial justice and health equity. We do this by assessing how we do our work. How do we walk our talk as an organization that names racism as a significant root cause of health inequities? And we believe that in order to do this, we really need to hold a mirror to ourselves and look for areas of growth. Another key piece of this work is engaging our staff more broadly in an inclusive process. Membership is open to anyone who is interested, and so since 2008, ARAC has been a voluntary committee, met regularly twice a month, each month, and builds agreements as a committee through consensus. This has not always been easy and has involved many difficult discussions, which I will touch on in following slides. And we also work to be equitable in terms of our membership and participation. We devote much of our time to targeted recruitment in terms of racial representation, position, and bureau within our organization. The other key goal within our Anti-Racism Advisory Committee is to cultivate a racial justice learning community. We do this by offering ongoing learning opportunities for our staff. So now I'll go into a few objectives from our committee. And the first piece we really want to emphasize as being crucial to foundations to our work was developing some common language. In 2008, ARAC, the Anti-Racism Advisory Committee, began a process of researching institutions and organizations in the racial justice field to support the Commission's agreed upon definitions. We developed agreements on these terms that led us as an institution to using these terms consistently. A key takeaway from this was the process. The process was so crucial to the outcome that we developed. Again, it was really difficult, as you can imagine, having conversations in the workplace about racism. And so the result of which created really rich and meaningful outcome by going through this as a group in an inclusive process. And so as a result, we developed almost 20 terms in terms of how we describe racism, what we mean by racism, so that we're all on the same page in doing this work. The next slide will show an example of one of those definitions. So here's our definition of racism. Racism is a form of oppression based on socially constructed concepts of race that is used to the advantage of the dominant racial group, whites, and the disadvantage of non-dominant racial groups. As you can imagine, again, this was a difficult process to build agreement on this shared definition, and is not a definition that is used by everyone. And I think it bears repeating that as a public institution, it's pretty incredible that we are able to not only do the work, but are encouraged to do the work that yields results such as this. The next piece of the Anti-Racism Advisory Committee's work was developing an agreed-upon organizational identity statement that was in line with our racial justice lens. An organizational identity statement has significant weight as it communicates who we are, what we are working towards, and how we work. In 2011, we entered a process to align this statement with our racial justice framework, and this meant having many internal meetings with staff across the Commission, as well as external meetings. We met with 300 individuals, approximately, and the info collected was compiled and narrowed down to create a final product approved by our leadership and the board. This resulted in an organizational identity statement that provides a clear link between racism and health outcomes, a revised mission statement, a new vision, and a new set of guiding principles. Our next slide gives a brief glimpse at what that means in practice. I won't read through it all, but I encourage you all to check out our public site, bphc.org, to read the full statement. We are all really proud of what we created and also what the process was to get us there. It was an incredibly inclusive process, which we feel resonates in our outcome. The next piece of the Anti-Racism Advisory Committee's work is the development of equitable policies and practices. This is a key piece of our organizational change process. The development of internal policies and practices that promote racial justice and health equity. The committee strives, again, to be a representative body, but still we want to make sure that our recommendations get wider input in terms of the direction of the Commission and how our Anti-Racism Advisory Committee can support that process. In order to do that, in 2013, the committee administered an all-staff survey. The process was to better understand staff perceptions of issues related to race and racism and identify strengths and opportunities for growth. We got a 45% response, which was pretty great, and contributed to the development of the specific recommendations that resulted. To take a step back, or a couple steps back, just even creating this all-staff survey took many months. Lots of conversations in terms of what we can ask, what kind of information we're willing to tap into. And so, again, a key piece of the process is this isn't easy work. It takes lots of momentum and a group collective effort. After the administered survey, we collected the information, met with many staff members individually, drafted many iterations of recommendations, and built agreement with our leadership. As a result, we created and adopted policy and practice changes. And a key piece of this as well was closing that feedback loop. We went back to our staff through town halls across many of our campuses at our organization and shared with them, what did their voice contribute to? What was the overall result of the survey? How did their voice get implemented within the development of those policy and practice changes? So the next slide will show you specifically some of the content areas that resulted from that survey. These were the two primary priority areas that developed as a result of that process. One, to ensure equal opportunities for advancement to leadership positions. And the goal around this was to increase diversity by ensuring equal opportunities for advancement for all qualified applicants to key decision-making leadership positions. The other was professional development and retention. And the goal for that was to establish career pathways and develop improved training and skill building, promotion and retention, particularly for our lowest paid workers. As a result of this process, in addition to specific policy changes, we developed work groups, cross-commission work groups, to really think hard about how we can enhance our practices and really target these approaches using equity as its foundation. And again, I'll remind listeners to add in questions and we'll take them at the end. And at this point, I will hand it off to Brad Cohen, who will speak on staff development at BPHC.
Thanks, Michaela. So we know that we're trying to not just share facts with staff, but to really transform our organization and engage staff in all parts and levels of the organization. So we knew that doing staff development and offering opportunities for staff throughout the organization to really engage with both the content and the process of the change that we're trying to create would be essential. I'll talk about how we developed that training, the content of the training that we did, and the results, some of the results. So our overall goals and objectives for conducting professional development for staff are to increase staff understanding of the concepts of racial justice and health equity, put everyone on the same page as far as the language that we use so that we can have conversations and move forward as a group, and equip staff with strategies, resources, and tools in order to think about their work and what might be added in order to create justice in the city and improve health outcomes. We're also deeply invested in creating an ongoing culture of learning throughout the organization that everyone can participate in. So the training that we conduct consists of 22 hours of training that all staff participate in. This was an organizational decision that came from top leadership and was supported through the ranks of leadership down to staff, so that all staff would have the advantage of attending trainings. We also have a rather robust evaluation of the professional development that I'll also talk about a little bit. And we're very fortunate to have resources which have all been provided through our internal funding. We have a full-time senior trainer for health equity who develops curriculum and also works with and organizes a cadre of workshop facilitators who come from throughout the organization. So how do we build support for such a robust investment in staff development and training? One really important thing is that we're part of an overall initiative. We're not conducting training for the sake of training or as an isolated strategy. It's part of the much larger strategy that we're all presenting today. The training that we do today follows previous trainings. It's not the place that we started. We did previous rounds of training with the People's Institute for Survival and Beyond and Visions specifically. And we also listened to staff. So what's here on the slide is a reflection of some of the feedback from staff that they gave during a series of meetings and surveys conducted in 2008 by our then Executive Director, Dr. Barbara Ferrer. And they talked about how the extent to which staff felt that their work was connected to racial justice and health equity, and we asked what would support them in doing that work. And staff indicated strongly that training and strategies for public health programs would be really key and supportive of them stepping into that work. So what is in the training? This is a very brief outline of the initial 14 hours of the 22 hours. We conduct a 2-day workshop which lays out the essentials of the conversation. So we spend a good amount of time creating a learning community. We know that staff, like all of us, are not used to talking about the dynamics of race and racism, in particular in mixed race groups. It's something that's not familiar, and so we need to invest ourselves in figuring out how each group will do that with one another in a supportive and productive and courageous way. We talk about what we're trying to create as far as healthy communities, looking at assets and threats, and we really ground the training and the conversations in data about health outcomes. So although we're talking certainly about the broad picture of racial justice, we're focused very specifically as a health department on health inequities and examining the current status and our vision for shifting them in the future. We, of course, spend time talking about the social determinants of health and how we can have an impact. And I've listed here on this slide some of the specific videos that we use, because videos have been a really effective tool for us in not only touching people's knowledge, but also touching them in the heart. We talk about definitions and discuss levels of racism, different forms of racism, have conversation about privilege and the role of bias in how services get shaped and delivered, and we back up and talk about the origins of the system as we know it today, and we do that through a historical understanding of structural racism. We use some very helpful videos there as well. And we wrap up that 2 days talking about leaning into strategies to achieve health equity. This 2-day training is then followed by a series of practice workshops, which are the place that we will be really drilling down into the specifics of the skills and the approaches that staff can take in their specific work to have an impact. All of these trainings, you'll see, are currently in development. Our challenge in all of this work has been answering the call for very specific public health strategies that address inequities. We know that we need to build skills not only internally, focused on our own policies, our structures, and our relationships with one another, but also externally in our programming, and how we as an agency partner with other agencies. So what has come out of the training? We're fortunate to have a rather robust evaluation strategy. We do pre and post surveys before and immediately after training, and then follow up 8 months later, and I'll show you some of those results. We do a satisfaction survey at the conclusion of each training. We conducted interviews with workshop participants, as well as workshop facilitators and other key leadership in the organization, and we will be looking at program budgets and logic models and developing some case studies. What we've found is that people overall are very engaged and by the training, and that it really has supported their ability to have conversations, to have difficult conversations, and to put together the information in their life experience, sometimes in very new ways with a new perspective, which is helpful. And we've found that folks leave saying, well, what can I do? What are the next steps? And that's our next step as we develop to make it applicable to work. So here on this slide, we have just a bit of the data. What we see here in the light green are pre-test survey results, and in the dark green is our post-test survey results. And all of these are statistically significant changes that were in the direction that we were hoping when we constructed the trainings. What this tells us is that we started with a staff that had a high level of understanding of the issue, and that has been strengthened, that we've moved forward. It tells us that our training has been an effective strategy in reinforcing and increasing alignment of staff with the goals of health equity, which we know is really essential if we're going to truly transform from the inside. What are some of the other outcomes? We have successfully trained almost 1,100 of our staff in the 2-day core workshop, and really significantly, we've built the capacity for leadership from within. We have our cadre of, at its peak, about 20 staff at any one time who have been trained rather intensively, not only in the content about racial justice and health equity, but also in the skills to facilitate difficult conversations and to train and facilitate training sessions. And that pays off in many other ways. And we also have these staff who are distributed in all of our programs and bureaus, who can then look within and talk with colleagues on a one-on-one basis and take leadership in shaping what their programs look like moving forward. I'm now going to turn over to Michael Suhu, who is going to talk about our work in language justice.
Thanks, Brad. Good afternoon, everyone. My name is Michael Suhu, and like Brad said, I'm going to talk a little about our working group that we're calling Language Justice. I want to remind folks that they can type in questions right now, and we will try to get to as many questions as we can at the end of our presentation. Next slide, please. So Vivian alluded a little in her intro to Boston's particular racial history. This is a slide that we've borrowed from our friends at the Boston Redevelopment Authority that still makes me excited. You know that feeling when you see yourself reflected. It's a map of Boston of the top 10 countries of birth amongst foreign-born populations. And you see, really interesting concentrations in the middle of the city, but also all over. We're everywhere, we being people of color. We're a majority-minority city, as Vivian mentioned, and this might be a little different than the picture some of you might have of Boston who've never actually visited or see movies and media representations. We're a growing, diverse, ever-changing city. I think if you look at our Boston Public Schools, the latest figures are at least 3/4 of the students are either Black and Latino. So that's a very emerging trend that we've got our eyes on. Next slide, please. So really, the working group that I'm talking about is about language access, but we've framed it by calling it language justice. It's an aspirational frame, and I think it's beneficial to go over the distinction between the two. So, it's a both and. The group wants to pay attention to access, general communication, but in that frame, it's usually just unidirectional for either interpreting or translation, and it most definitely flows from the dominant language, most often English. And English is at an advantage over other languages, and inevitably this frame segregates participants. If we take a justice lens, it tries to make communication multi-directional, and it flows according to lots of different cultural norms, so it allows people to participate, with cultural pride in speaking their own languages. And in the justice lens, all languages and people are on equal footing, and English is not at an advantage over other languages. So it incorporates a social justice approach. Again, aspirational, but we found it really useful to frame it in the larger racial justice and health equity initiative that we're talking about today. Next slide, please. So the goal of the working group is really to improve the Boston Public Health Commission's ability to serve clients whose primary language is not English consistently across all programs and bureaus. So that's talking not just about spoken interpretation and written languages. It's talking about how agency messaging goes around, the lack of uniform practices and policies. Some programs have budget line items for translation, some don't. There isn't a centralized process yet to think about language access. So obviously, identifying professional development opportunities in language skills and cultural competency is a big issue. But we've also thought about putting it in financial terms, in terms of streamlining processes with vendors. So the next slide, please. So some of the big projects the working group has been tackling is we're really excited about this public health glossary that we've developed of some of the most common health equity and racial justice terms. And to think about the 5 most used languages in the city of Boston. So that would be Vietnamese, Chinese, Portuguese, Haitian Creole, and Spanish. And through a process of working with the staff and our external community partners, we focus grouped 5 different glossaries of just the terms, not the definitions, but just the terms. And now that glossary is available to all staff on our internal intranet in all the 5 languages and in English. And most importantly, our vendor, our subcontract vendor for interpretation and translation, has agreed to use these glossaries in all the products. And we also know that we need more data, and we are in the process of administering a commission-wide language capacity assessment, which I'm very excited to report that we've gotten the green light just recently to roll out this fall. It'll hopefully be much like the survey we just heard about from the Anti-Racism Advisory Committee that will produce some really concrete practice and policy changes. So now I'm going to hand it back to Vivian Morris.
Thanks, Michael. So now I'm going to talk about our 5-year Boston Health Equity Goals. We have 3 goals. I'll go through them very briefly in describing them, and then a little bit more about their history. We have a goal of reducing the obesity and overweight rates among all Boston residents and reducing the gap between white and Black or Latino obesity and overweight rates by 20% for adults and 30% for school-aged children within this 5-year time frame. We also intend to reduce chlamydia rates among all Boston residents aged 15 to 24 and reduce the gap between white and Black/Latino chlamydia rates for residents aged 15 to 24 by 25% within 5 years. For low birth weight, we want to reduce the low birth weight rates among all Boston infants and reduce the gap between white and Black low birth weight rates by 25%, again, within 5 years. These health equity goals represent a cross-organizational effort to align our practice with our mission. They speak directly to our intent to be held accountable in our efforts to address racism and the social determinants of health. And for us, it was very important to set this 5-year time frame because having a time frame helps us enhance our accountability across the Commission and accountability to our community partners and those in the city, and also gives us an ability to measure our progress. You may wonder how we selected these 3. Clearly, as a health department, we're responsible for the full health of all residents in the city of Boston, and we are looking to both reduce rates and close gaps around every health issue. But we thought we should start somewhere. And in these 3 issues, we had issues that each was a long-standing problem when we looked at the data over many decades here in the city of Boston. That data showed us that there was a significant inequity in health outcomes between groups in the city. And for each of these, we thought that there's this possibility, more than a possibility, we felt there was a probability that we could make a difference because there were promising practices that we could look to help us address each of these goals. So we're now at the midpoint with about 3 to 4 years of available data, and we'll have a final report when we have data that goes up through the year 2016. And with that data, we should be able to give a more complete picture of what we're able to do to close the gaps. A little more on chlamydia. We developed over time in preparing to set these goals, looking at the many ways that we can impact this health problem. The framework for chlamydia includes improving surveillance data through implementation of reporting regulation that allowed us to get data on both incidence and also treatment of sexually transmitted diseases in a more in a much more regular and timely way. And that has been really important to us. So now we get data directly reported to our health department. Our infectious disease bureau nurses provide directly observed treatment and expedited partner therapy for selected cases. And for those who may not be familiar with expedited partner therapy, it became legal in Massachusetts in 2010, and it allows healthcare providers to treat the sex partners of patients by prescribing medication for partners without prior examination. That is that if a person goes to a physician for treatment for an STD like chlamydia, the clinician can give treatment for the partner without the partner have to come into the office to be seen directly. We also do as much as we can to increase awareness and improve testing throughout the city. We have a chlamydia advisory group that's convened by our Infectious Disease Bureau that meets to discuss best practices and new ideas. And we also support community-based agencies to provide sexual health education for teens and young adults in the target group. And with that group, we learned a lot about how to do education generally in the community and provide services to the public, including services to students in Boston Public Schools. An example of a campaign that we're running in order to address the issue of chlamydia is the It Could Be Hiding in You media campaign. This campaign uses a camo or camouflage tagline that was developed with input from youth in high-risk neighborhoods. The name and the camouflage theme of the campaign supports the message that chlamydia is an invisible infection, and many of those infected have no symptoms, but of course a laboratory test can indeed confirm an infection. The youth told us that there were a number of barriers to them getting regular assessment of their health status, and we learned from them and tried to address those. They felt that needing parental permission for STI testing was a barrier. Not having insurance was a barrier. Just the stigma of talking about chlamydia itself, and there not being many available sites. So in coming up with our campaign and our work plan, we tried to address as many of these as possible. In our literature, we have listings of all of the hospitals, clinics, and health centers that give free and confidential testing. And we put this message out, as Michael said in his work describing our efforts to be more language just, doing this in multiple languages. The youth-friendly language and approach of this campaign is also geared towards promoting dialogue among youth, because youth being able to talk with their sexual partners is a very important part of this campaign in order to encourage prevention and treatment. So the data to date, we have 2 data points for looking at changes in chlamydia rates in Boston in our target group. And we actually found that the chlamydia rate for Black residents from 2011 to 2013 decreased by 20%. The rate for among Latino and white residents during that same time frame remained stable. So what we could say is that we actually reached our goal, our 5-year goal, to reduce the gap in the ratio between blacks and whites for chlamydia within 15 to 24-year-olds. We more than reached our goal of 25% and actually had a 27% decrease. But not that we can feel too good yet about this intermediary data. First, because as we know, the chlamydia rates are still extremely high among black residents. And indeed, black residents still have the highest chlamydia rate at 1,095 cases per 100,000, and a very close second in Latino residents in the same age group. So And if you compare the rates of chlamydia among Black and Latino residents to that of whites, we find that the rate is 5.5 times higher than for whites among Blacks and 3.5 times higher than for whites among Latinos. We also found that just having the accurate data from which to draw conclusions is sometimes an issue, and this is a case in point, where a large proportion of the cases that we see don't have race ethnicity data. So again, we can't be totally sure that we've hit the mark. Now to talk about low birth weight. As I mentioned before, our low birth weight goal is to decrease low birth weight overall and to decrease the gap by 25%. Health programs are now moving beyond only focusing care during pregnancy or preconceptual health, conceptional health, to looking at the life course of women. So we're doing that as well in a number of our programs. We're focusing on ensuring that high-quality prenatal care happens. We're offering lots of support to women in our communities through a number of programs like centering pregnancy programs that provide group support for pregnant women and father support groups. And we also are trying to address some of those social determinants of health. And one example is Healthy Start in Housing, and I'm going to describe that a little bit more. Healthy Start in Housing is a project that we began in 2011 so that high-risk pregnant women would not have to deal with one additional stressor, which is the stress of imminent homelessness. This was a partnership between the Health Commission and the Boston Housing Authority to work with clients to get them enrolled, get them their applications in, help them find an apartment, and then provide ongoing 3-year intensive case management so that women would be able to realize their life goals at the same time maintain stable housing. And what we found was that the Housing Authority had a goal of increasing stability among their residents, and we have a goal of having stability among women who are at risk for low birth weight infants. And so our goals were very much in alignment, and it's been a win-win on both sides. The data for low birth weight shows that we have had a significant decrease in overall low birth weight rates in Boston, and we've had a decrease in the Black low birth weight rate from 2010 to 2012, but the gap, unfortunately, didn't change significantly. So again, while we have been moving in the right direction here, we can't say that we have reached our goal in the midterm. For obesity, our goal was to reduce the rates of overweight and obesity overall and decrease the gap by 20% for adults and 30% for school-aged children. And we've done that by looking at and implementing policies and practices in a number of different arenas, focusing on physical activity and healthy food and drink options in childcare settings, school and out-of-school time settings, the community, and even here at work. I'm going to give an example of one project that we have been doing here at the Health Commission, which is the Rethink Your Drink Healthy Beverage Initiative. And this is a tool that you see here on the left. It's a stoplight tool, and it's used in point-of-decision information posters and all kinds of ways that we get this message across in many different places, grocery stores, schools, colleges, universities, healthcare institutions, community-based organizations. Throughout the city now you'll see this, and you'll see it near the point of purchase to encourage those of us who are thirsty to choose water first. And again, I wanted to just say, of course, we all know that sugary beverages have been found to be a significant source of excess calories, and just making that switch from sugary beverages to water can have a significant impact on obesity rates. We haven't seen any significant changes in the obesity rates in Boston between white, black, and Latino adults or high school students during this time frame of 2010 to 2013. However, the fact that our rates in Boston are now stable is pretty promising, given that overall, over the last few decades even, obesity rates nationally have continued to go up. One positive note, though, we can say is that when we looked at data on soda consumption among high school students, we found that there was a very significant decrease among black high school students consuming sodas, going from 28.9% of students drinking one or more sodas a day to currently 16.2%. So, in conclusion, for our health equity goals midpoint, we found that the data trends highlighted here support the continued need for policy, systems, and environmental change. While we're encouraged by the direction of the data, we also feel that lasting and significant downward trends in these three health areas depend on systemic policy and programmatic approaches that address root causes like racism and its effects on the social determinants of health. So what have we learned overall as an organization as we've been on this path towards reaching racial equity and social justice? Well, first off, we learned that you have to be explicit about racism before you can address it. Also, that implementation requires constantly considering feedback, including what we learn from racially explicit data. Data collection and data analysis take time, and just building the capacity to obtain the data that we need is its own process, as we saw that in some cases we don't actually have the best data to be able to determine if indeed we're making the impact we want to have. This work is very complex. It's not linear. It takes a lot to make big changes in a large city agency, and it takes a lot of time. We heard that in each of the presentations that was given, how complicated, sometimes cumbersome, the need for buy-in at all levels of our organization. And yet, we found that if we all work together, we can indeed improve our work. We need everyone. Having a workforce made up of city residents has been a big plus for us, as our staff bring perspectives and responsibilities as both employees and residents to the table. We've learned that we have to work across silos to support learning and ensure cross-organization capacity building. Having a strong internal leadership has been extremely important for us, because in a large agency like this, leadership really does matter. And working collaboratively with partners in the community, in the city, state, and federal government has definitely strengthened our work. So for us now, we are now in the process of having just completed a strategic planning process of beginning to look at how to implement our strategic plan. And our strategic plan has written completely throughout it, looking at and making changes to ensure that we are not only a racially just organization, but that our work in the communities and promoting good health is racially just as well. The next thing that we're doing is working on our organizational change theory. We need that. Our theory of change is going to help us further clarify our approach and ensure that everyone in our organization is more directly involved in the transformation that we're seeking. I'd like to now open it up for questions. One question that we got asked if we could speak to the challenges that have arisen with individuals who didn't necessarily find health equity lessons or framework valuable or helpful from the get-go. What helps in guiding that conversation? So, Brad, do we answer that?
Sure. Well, I can give one perspective at least. So there are three things that we've found particularly helpful during training sessions. The first is to listen really closely. In training, we try to hold a learning space rather than to engage in debate or to correct people. So we allow people to express what they need to within the parameters that are set by the group for safety and having courageous conversations. A second tool has been to ground our conversation in data and in history. It's been really enlightening to see how much learning history is needed, how the ways in all of the history that we are not taught in this country. Some examples are convict leasing, FHA policies that led to segregation, geographic segregation in housing, that then lead to the biases that we hold today, and to ground the conversation in data about health outcomes. There's a way in which talking about history and data allows people to come toward the material in a way that opens them up, and that they seem to find helpful as well. And the third thing is to be very clear about our framework and what we as an organization believe is necessary in order to create change. So while we might have conversations with people who disagree, and we actually hope to, because that's the only way that they will that they may shift, we're clear in what the expectations are and the direction that we're moving as an organization.
Thanks. We have another question that just asked about how our race-based dialogues are structured and what the process for those dialogues look like. I think this question may be talking about the dialogues that we have as part of our training. There are clearly dialogues that are happening throughout our organization, some informal, some more formal. We're finding that a number of our programs within the organization are beginning to have dialogues internally because this comes up in our work. So we can talk a little bit more maybe about the structure of our trainings or some of the listening sessions and other things that we have here where in addition to the sort of regular formal trainings, we have discussion groups that some of which are done by the Anti-Racism Advisory Committee, led by them.
Hi, this is Michaela. I will speak a bit about the learning opportunities that the Anti-Racism Advisory Committee supports. So our aim is to have quarterly opportunities for staff to engage in slightly informal conversations. So we know that the work that we do is grounded in data. We see the numbers. We know academically, intellectually, what this work means. But sometimes we get lost in the numbers and lost in the heady stuff. And so we work to offer space where staff can connect and have honest conversations about what this means at the individual level. And as people, we come to this work as individuals, residents of Boston. We see ourselves in the numbers. We see our family members in the numbers. And so we don't want to lose that heart space when we are engaging in this work. And so the conversations are usually guided learning opportunities, but also the bulk of those opportunities are open dialogue, guided conversation, safe space held by trained facilitators, but not heavy in curriculum. It's an opportunity for, again, open dialogue. We've done it through brown bag lunch sessions, engaging in observing documentaries, media, topical conversations. We hold once a year a Stand Against Racism event, an event sponsored by the YWCA that is an opportunity to uplift that racism still exists and that we collectively can address it. And so we try to have as many opportunities as we can to support ongoing learning, conversation, and to build the muscle to have these conversations comfortably.
We also know that there are some conversations that staff may be interested in having and need to have that they would feel more comfortable and might be more productive to do in the community outside of a work setting. So dynamics are different within the work setting, and there's certain personal exploration that folks may find more freedom to engage in outside of work, and we encourage them to do that as well.
So, if there are no other...
There's one question from Jill. Oh, same. Sorry.
So if there are no other questions, again, we want to thank everybody for both listening in, and if you have future questions, we look forward to continuing this dialogue with you in direct and indirect ways. Again, we can be reached through the National Collaborative, and we are part of this process with everyone. So we are both learning as we do and hope to continue to learn along with you. Thank you.
Yes, and I would like to thank our colleagues in Boston. This is wonderful work. This is a wonderful example of how to really focus on processes. Just a reminder to all of the participants, next week you'll be getting a thank you for participating email that will include the link to the recording with a PDF of the slides and contact information if the Boston team would like that as well. Thank you very much. We appreciate your time and your continued struggle with us to improve the health of all. Have a great afternoon.